Hey guys, welcome back to the Foam Frat podcast. We got a cool episode on the T1, the Hamilton T1. We had on Joe Hylton. He actually works for Hamilton. He's been a resource for a lot of vent questions and a lot of stuff that's come up specifically with the T1. In this episode, we go through a bunch of the nomenclature, a bunch of the philosophies, some strategies. So I think you guys will enjoy it. Sam, you took a listen to it. What were some of your thoughts?
Yeah, I have some points for a wrap up after we roll the tape, but I was thinking just in general that if you're brand new to mechanical ventilation, some of the points are going to be a little bit nuanced and they involve these scenarios where maybe you haven't been there yet or you haven't developed this workflow where you kind of always do this one thing or another and you're just learning. But I was thinking like you could simulate a bunch of this stuff and that simulation will up your game pretty quick. I was messing around after I watched it last night and took some notes on it. I went back into the office and I was messing around with the ventilator and stuff. And I was like pulling out this, piece of clamped flex tubing there. And I'm like simulating the resistance by like putting the clamp on there. So this is like increased resistance, or you can even like clamp it back here and that'll like give you a little bit of decreased compliance. Or, if you want to act like somebody's triggering the ventilator, just have them kind of like expand that test lung a little bit or sneak some leaks into the circuit or, some weird obstruction in there. You and I used to drill that kind of stuff with new hires all the time with the vent where it's totally messed things up. And then they come in and they have the vent is alarming and who knows what somebody did to the tubing or the vent or the test lung. And you'll start to develop these workflows and kind of get a little bit of muscle memory for, okay, this peak is crazy high, or, oh man, this is leaking like crazy. So some of the stuff is a little bit nuanced. Yeah, simulation will take you a really long ways. But yeah, great discussion.
Yeah, the employees at Lifestar learned what the waveform looks like when you have a donut hole in the exhalation valve. So
That's correct. You never knew what somebody's doing before you came into the room. You just heard the vent alarms and you walk in and you're like, it might be a donut, it might be a leak, it might be anything pretty much, yeah.
All right, well, we'll roll the episode and then we'll come back at the end and just do a summary. We've been trying to get you on and align our schedules to talk about ventilation. You're the ventilation guru. I feel like there's you, Brian Winchell. There's a couple of guys I always go to with my ventilator questions. And I just put out a blog called T1 Hacks, 5 Tips You Should Know, a real clickbait title on the blog. And I went through several things that I thought are important because when you're transitioning from an LTV 1200 or maybe a Rebel or different types of vents that people have on their, as Winchell calls it, their ventilator resume, and then you move to the T1, there's a little bit of a learning curve, right? And so I thought we could go into some of these points within the blog. Now, have you seen the blog?
I've read the blog.
You've read it. All right. Well, I was worried that you were going to come back and you were going to be like, all right, man, this is horrible. None of this is accurate. You need to take it down.
No.
And I start off by talking how it's a strictly pressure ventilator. So when you look at the different modes of being volume or pressure, there's some confusion because it'll say, that there's this CMV, there's this volume mode. However, the T1 is just a pressure driven ventilator, correct?
Correct.
How can we conceptualize why it says volume?
Do you mind if I share screen? You can see the vent screen now? Perfect.
Yeah,
Good deal.
I see it.
So just to clear some ambiguity up, when your machines are set up and they're configured at purchase, there's some things that we put in to have the machines speak the right way. You can put in your configuration type that you want, whether you want IDE ratio or I time. But if you look at this second line, you can see you can do the terminology for your volume breath. You can do the SCMV for what I prefer, the APV side. It's the same thing, but it's wording the modality a little bit differently. In essence, either way you have it, this is a PRVC breath. No matter
what does APV stand for?
Adaptive pressure ventilation. And it had to be called that way because another ventilator manufacturer that invented PRVC, they trademarked PRVC. So that modality has 5 or 6 different names on the market now because everyone decided to put something very similar to it on their machines, but they couldn't call it PRVC. So they had to invent other ways. So you may see autoflow, you may see AC, volume guarantee, BC plus, APV. Those are all PRVC variants. And there's going to be subtle differences in the algorithm of how the machine handles it. But in the end, it's a pressure regulated volume control breath.
Meaning I'm saying this is the volume that I'm trying to get to. The ventilator is going to give a breath and it's going to say, hey, I need to either go up on that pressure or come down on that pressure to hit that tidal volume, correct?
Correct. And I think an easy way to put it out there and kind of kill two birds with one stone, you mentioned the machine being a pressure ventilator. For folks that don't use the T1 that may be watching this, if you're on maybe a Z-Vent or a Revell, when you do your volume control breath, you're getting that modality, one constant, and then you have a variable that's going to be out there. So if you choose VC, your volume is going to be your constant that you put in. Your airway pressure is going to be the variable that's there based on compliance resistance and any patient effort that occurs in place. When you look at a PRVC type mode, you're putting in the same settings, tidal volume, I time, PEEP, FiO2. All those are the same. But the difference is now your ventilator is looking at the tidal volume you told it to give versus the exhale tidal volume that it sees. And its goal is to make the exhale tidal volume very closely match what you told it to deliver. So now pressure is still variable, but your machine is actually trying to turn pressure up or pressure down to hit the tidal volume target that you have. So the machine's trying to act a little bit smarter. And in some ways it's good, in other ways it's not very good. But that's the pressure regulated piece of it. The machine's trying to do two things at once.
Yeah. So when I put someone on the ventilator, typically, like whether this be a scene flight or, they're bagging at a hospital and I'm putting them over on our vent, I like to just go into PCV because I can manually do that, titrate that up to get to the volume that I want. I get a little impatient waiting for it. Is there any problem with that? What are the advantages of doing this as opposed to PCV? When does Joe Hylton go to one versus the other?
Neither's correct. Neither's incorrect. You're going to work with what you're comfortable with, obviously. One thing that may help if you're using the PRVC, the APV mode, is connecting to the patient before you start the ventilator. And the reason that's going to help you get to breath target faster. If you start the ventilator and your vent circuit's not connected, your machine immediately starts giving breaths and it sees zeros coming back.
That makes a lot of sense. Yeah.
So when it sees zeros, it's running down the rabbit hole and thinking, okay, I'm supposed to give 450. I'm getting zeros, more pressure, more pressure, more pressure. And then you connect and then you get this crazy tidal volume. And then it's having to run down this algorithm to correct what it sees versus connecting to the patient and then turning the ventilator on. Now, the very first breath, you get meaningful data back. You get a decent tidal volume. And by the way, for APV on this machine, the first 3 breaths are at a delta of 15. So that's its 3 test breaths that it gives.
So if it's not on a patient, you're just giving it bad information. It doesn't have
Correct.
good data to go off of.
Correct.
And that makes the algorithm take a little bit longer. And to be fair, even when it's connected to a patient right away, or even that scenario, it doesn't take that long, right? But it's one of those things where if I put somebody in pressure, I turn it up, I get it to where I want. And then if I have to go higher on my pressure to the fact that it's bumping against an alarm limit, it's mental that I can go in there and, I got to change that alarm limit. Whereas I feel sometimes when you put a volume in and you're not hitting that volume and you're seeing that you have a pressure limitation, I've seen sometimes if people don't understand that this is like a PRVC, and it will keep increasing that pressure to get that goal volume until it either hits the volume or it bumps up against that ceiling. That's the pressure alarm. And so if you're going in thinking this is a volume ventilator, you could be like, well, I don't understand this. Like on their ventilator, they're at 520 and on my 520, I can't get there. I'm only getting 300. And then you look over and you see, okay, their inspiratory pressure was higher or their total PIP was higher on that ventilator. Anything to add to that?
Settings come into play, obviously. Moving from machine to machine, pneumatics are different. So you are going to see some subtleties in what you see measured. They're usually pretty close, unless you have maybe a really horribly restricted patient that's knocking on ECMO's door. I've seen some machines have a lot of variability there, but that's almost an extremist type case that you see somebody that's needing way more than we can give them.
Mm-hmm.
Before we dive into that, a couple of things also to note. Depending on the software version you're running on the T1, that delay in PRVC might be longer. If you're running older software, the machine has a much tighter guardrail on how much it can change pressure. The new software, it can change up to 8 millibar of pressure on PRVC to get you your breath target faster.
So in the new software, it's making bigger jumps to get you there.
Yes, we call it fast APV, but the controller works much quicker. It can make a much bigger jump to get your tidal volume where you want it to be. So the software version can play into it, maybe taking a little bit longer to get the breath target to you. 3.0.x is going to be the better one, that software version.
Awesome. No, that's great information.
Yeah.
How often do you guys update that? Because it sounds like you're always working on these modes to try to make them better. Is it something where you should update this every year, or do they send out messages when they do an update?
Yes to both. I would recommend very much staying on top of your biomedical group. So when your machines do get PM'd, the newest software is installed. And going from 2.2.1, which is the latest old software, to the 3.0.x, that is a big jump. As you can see, it changes the screen considerably.
Mm-hmm.
Operationally, it's not a huge jump, but there's a lot in the background that's changed for the better that makes the device work well.
That's
So
awesome.
we should tell folks, if you're going from 2.2.1 to 3.0, we probably need to sit down with your education group and kind of run through what's going to look different, and so you don't freak out when your machines come back and you're like, oh my God, this is not what I sent you. What happened?
Yeah. I personally was a fan of the older color scheme, but this one's starting to grow on me a little bit more.
This one does so much more for the
All
better.
right. Well, the next thing I wanted to bring up is SIMV. All right. So I feel like there's some confusion because I hear people be like, oh, I'm a big SIMV person. I love SIMV. And then I ask them what type of patients they're putting on SIMV. And it's the patient that they just intubated, paralyzed, and are aside on a scene. And in that scenario, it doesn't make sense really for me to see them on SIMV unless you think they're taking spontaneous breaths, right? And the argument you typically hear or you're met with is, well, but if we hit bumps in the transport, in the ambulance, or in the helicopter, I don't want it auto triggering a full breath. I want it to be, at the SIMV, the pressure support. I don't find myself using SIMV a ton unless I do have those spontaneous breaths, which are, easy to see. You can see when the patient's triggering a breath and you go in and you allow a little bit of pressure support. How often are you doing SIMV, and what's the patient population that you're doing that in? Is there any benefit to doing it in the fresh RSI patient?
Good question. For the fresh RSI patient that's not breathing spontaneously, if you covered the mode up, if the patient's not taking a breath, you would not be able to tell if it's an AC mode or it's SIV. They look identical. You can't tell. The big difference is if spontaneous breathing occurs, then you can differentiate between the two. AC, your breaths are all going to look uniform. SIV, your spontaneous breaths are going to have a different amplitude for pressure, and your flow waveform is going to look different as well. But it really doesn't matter as long as you have your baseline control set to where you can maintain that patient's metabolism and you mainly provide oxygenation, get rid of CO2. Your mode selection there really doesn't matter. I usually am doing the CMV route, but if you've got the patient that is spontaneously breathing, and this is kind of where the road for me forks a little bit. If it's someone maybe it's a ground trip, going to rehab, I may have them in spontaneous
Sure.
because they're trucking along. They have a good basal rate. They can maintain themselves. We'll let them go.
Or like a patient is being ventilated through like a trach, or
Yeah.
something where they're
Something like
able
a
to breathe.
trach. The awake intubated DKA patient,
Mm.
we might be a good candidate for spontaneous because, as you and I both know, their brainstem knows what they need way better than you or I do.
Yeah. Do you want to go into spontaneous and just show us how that works?
So obviously the patient's rate is going to be what's driving it. We're going to provide them PEEP and enough inspiratory pressure to meet their flow demand. And here's kind of where people get in trouble. They look at this pressure support control. They think, we can do 8. And then you pop it on the patient that's a DKA and they're just flow starved as could be. And not incorrect, we'll turn the ramp down to 0 to try to make the controller respond quickly to the flow needs. But if we're trying to meet flow demands on someone, whether they're intubated DKA or even in a non-invasive patient that's just air hungry as can be, one of the best things we can do is turn up the pressure support because that's going to really give a big burst of flow on the front side. It's really taking you back to flow dynamics 101. What 3 things affect flow? The diameter affects it, viscosity, and then your tubing length. But if you look at P1, P2 gradient, your pressure gradient has a huge impact on flow rate. And when you turn your pressure support up, you're increasing that flow gradient. That's what's going to help with the air hunger more than anything. That is the biggest bang for your buck. And a lot of folks, they don't think to go to it or they're afraid to go to it. But that's going to help take care of that dyspnea, especially for someone awake on the front side. If someone takes a breath and in that first few milliseconds, they feel like they're having some dyspnea, you're never going to get your arms around it.
Mm-hmm.
But if you can ramp that pressure up and give it a big push on the front side, you'll often see the rate start to come down. And then you can start slowly titrating your respiratory pressure down.
And if they stop breathing, it's going to kick over into PCV, right?
Yeah, sure. It's going to kick over into apnea. If you notice on the left-hand side, you've got your apnea tab. So you've got a control set in place if your patient does go apneic. So you're covered. And your apnea time, by the way, is going to be in your alarms, 20 seconds.
Yeah, I think the main thing with the SIMV is, like you said, if they're not breathing, PCV, whatever mode you're in SIMV are essentially the same thing. The problem I have is when people think that they can fix the false triggering of it by switching over to SIMV instead of actually adjusting their flow trigger. So if I'm getting, and I don't see this a lot, maybe on the old impact ventilators or whatever, I would see this, but I don't see these false triggers. But if you did, how do you approach that? What do you do with your flow trigger, Joe?
So flow trigger is a big thing. This is one of the biggest things that we try to stress coming to the Hylton platform with the proximal flow sensor. We're often on other platforms having your sensitivity or flow trigger maybe here, or maybe in some cases here. And for that platform, that's fine. The big question is, for each device, all machines are different. They have some similarities. They have differences. Most machines have their flow sensor back inside the box. So if the Hylton were that way, or any machine, your vent circuit's 5 feet long. So you've got that much space between the patient and your machine. If your flow sensor's back in the box, then your sensitivity is going to have to be really, really low. If you're a stereo audiophile and you think signal to noise ratio, things like that, your sensitivity needs to be low in the machine to recognize the patient effort that's 5 feet away. With the Hylton, since you have a proximal flow sensor, there's no need to put your flow trigger this low. Your machine will auto cycle like crazy in adults with it that low. And that's why we recommend 5 is a good place to start. I rarely touch it, to be honest, even on the helicopter. But if you did see auto cycling, you want to bump up the flow trigger. That's going to make the machine less sensitive to patient efforts. On ground, I'm sure the roads in the rest of the U.S. are as smooth as they are in Charlotte, not. And your circuit may be bumping against the stretcher, can cause enough of a pressure change or flow change to make the machine think your patient's taking a breath. So we'll bump that up. And
If that's Brian calling you, tell him he's in trouble.
yes,
No, that's great. And the way I think about the triggering is like, there's pressure triggering and then there's flow triggering. And I think about like if you had like the old ventilators where you'd suck in and you'd suck that exhalation valve closed when you went to take a breath and it would trigger to give that breath. I mean, you had to work pretty hard. Now because of, and correct me if I'm wrong, but bias flow, you have this constant circulation during the exhalation phase. And so as soon as you switch to inspiration, it's going to instantly notice you're not getting as much back as it's sending out. And that's why you don't have to require so much flow in before you trigger a breath. Is that correct?
a couple of things have happened with modern vents. Back in the past, you had to pay attention to your sensitivity and your PEEP. So for example, if I had you on 8 of PEEP, and I had my sensitivity set at 4, for example, you would have to
for pressure.
4 for sensitivity. Yes, you would have
Okay.
for pressure. You would have to have a strong enough effort to lower your PEEP 4 below what I had sent for that machine to fire. You can think of the work that placed on the patient side.
Oh yeah.
Your more modern machines, and I admit this is an age type thing. PEEP compensated. That's what it meant when I was coming through the RT world. PEEP compensated. You looked at sensitivity compared to PEEP. Your more modern machines now have eliminated that. They're independent of each other. So whatever PEEP you set, that's what you've got. Your sensitivity, whether it's pressure or flow, is an independent variable, and that's not related to that. But I still see some old Newports laying around that still applies to. Not often, thank goodness. So base flow. Your base flow is serving 2 purposes, or bias flow, same thing. Number 1, you've got a fresh flow of gas through your circuit to keep CO2 washed out. But secondly, that is one of the ways your machine is maintaining PEEP. PEEP on every mode except APRV, or high frequency ventilation. You're using expiratory resistance to deliver that PEEP. So think of your COPD patient doing personal breathing. They're giving expiratory resistance. Your expiratory valve is not a simple, fully open, fully closed type thing. It's got a variable of thousands of places to deliver back pressure. So when you say, we're going to put Tyler on 5 of PEEP, we set the machine to 5. The machine is going to look at the combination of the base flow and how much that expiratory valve needs to be open versus closed to keep 5 of PEEP at the flow sensor. So that's where your bias flow comes into play. Your Hamilton, compared to other machines, that bias flow doesn't change. Other platforms, when you change sensitivity, the bias flow changes. So you have to be cognizant of that, both from maintaining your PEEP and from a gas usage standpoint too. But that's kind of where your bias flow comes into play. Flow trigger actually is totally independent of your bias flow. I'll show you what I mean. So if you look at 5 liters a minute, you're thinking, wow, that's a lot of gas to move. But when you're looking at patient effort, we're not really breathing on a per minute basis. We're breathing at a kind of more of a per second basis.
Mm-hmm.
So when you look at that 5 liters per second now, you're at 83.3 mLs. And that's more of the change that the machine is looking for to recognize, hey, this patient's trying to take a breath. I'm on fire. When you break it down.
No, that's super interesting. Yeah, in my brain, I'm like, okay, well, if I have this bias flow during exhalation, if I'm breathing, if I'm sucking against that, then that's going to make it easier than me having to suck all the ways back to the ventilator because it's noticing those changes. So that's
Right.
an interesting point there. The next thing I wanted to get into a little bit is the monitoring tabs. So
Okay.
I mentioned in this monitoring page 3, that's where I tend to get like most of my information from. Not that there's not good information everywhere else, but I like 3 because it gives me my RINSP, my CSTAT, and my RCEXP as well. So when I'm looking at this, my thought is, okay, if my inspiratory resistance is 30, 40, 50, my C-stat's probably not going to be that accurate because I can't really get a good picture because I can't see past the airway at that point. The airway's so constricted down. Whereas if my R-insp is, 10 and I look over and my C-stat's really low, it's 18 or 20 or something like that, I think, well, I got to be really careful with the pressures. This looks like sick lung. And the reason I am looking at those pressures is because if I crank up my pressure really high in like an obstructive patient to get an adequate volume, I feel better about that if the R-insp was high as opposed to the R-insp being low and just having poor compliance. So how do you use these? Is that a fair summary of a way of utilizing those two?
It is. Depending on the physiology you treat, they can play upon one another. And some of it may fall back into your VIT settings. If you look at your R-insp setting for RAW, you may see it listed in other places. It's all measuring airway resistance. So that's a calculated number that you see on the device. Physiologically or clinically, when you're looking at that R-insp, depending on the text you're referencing, anywhere from 10 to 12 centimeters of water per liter per second is where you're looking. That's kind of your threshold. When it creeps above that, and then the machine's letting you know that your airway resistance is becoming a problem. Yeah, you have to really step back and take a look at it. If Tyler has an event and he needs to be intubated and he's got a 5.5 ET tube in him, his R-insp is going to be high, and we expect that. There may not be anything wrong with him from a pulmonary standpoint, but the conduit, the connection between the machine and the patient, you've got a definite restriction in flow there. Or it could be upper airway. If you're doing non-invasive and you see the measurement there, it could be a tracheal blockage, anything distal. There's where it gets a little more difficult. Then we have to listen or maybe even have to rely on maybe imaging this done to get around that. But whether it's the ET tube, whether your tracheobronchial tree is causing that, if there's any restriction that's going on, you're going to see that R-insp go up. And clinically, you can really see it get to a high number. I've done a couple of case consultations for other programs. I've seen it myself using this device clinically, where you might see a ridiculously high R-insp number.
For the R-insp on our Hamilton T1 little reference card we make, we said that if you saw increased resistance, confirm no obstruction in the tube circuit, suction if needed, utilize the obstructive strategy for ventilation, and then assure that the inline suction is not obstructing the flow. Because I've seen that way too much where they leave that in a little bit and now all of a sudden you're meeting resistance. Is there anything else you'd add to that list as like a quick correction method of going through high R-insp?
Yeah, definitely rather than your dope mnemonic is a good thing to do. That's not going to be wrong for anything that's acutely causing these issues to occur. And from more of a medical standpoint, I'm going to try to paint a picture for you. It's just taking the machine while they get used to it. You can see the R-insp is really, really rocketing up. I've seen that R-insp be as high as 120, 130 in some patients.
Wow.
That's an asthmatic. And usually you can notice here that I've got the R-insp really high, but the static compliance is acceptable. You're at about 60 still. So in this case, looking at both of those numbers, you could say it's really an airway resistance issue.
Mm-hmm.
What a lot of us see on the clinical side is we'll see high airway resistance, and that comes with high CO2. And someone has done this.
Mm-hmm.
They've turned the respiratory rate up to try to blow CO2 off. Now, watch what happens to your C-stat number.
It's going recalibrating.
Yeah, you're going to watch it start to come down because at some point your patient's going to become over-distended.
Mm-hmm.
And you'll see a high R-insp and a low C-stat.
Yeah, whenever I see that R-insp going up, let's just say like an asthmatic, it's been stressed that you want to do a prolonged exhalation time because you don't want them to trap air. But I feel as if in the severe cases, you can see people go too far to that extreme to where they increase the exhalation time so much that they're not even getting the air in the first place. and you see your inspiratory
Right.
flow wave go up and then shoot down right away. And we had a patient, we walked in and they're like, yeah, severe asthmatic. The exhale tidal volume was 45.
Mhm.
And you look at the flow wave and it's like they may have came in with asthma, but that asthma resolved. And now we almost have this iatrogenic asthma because we're trying to get this air in so quick that it's not actually going to get any air in. And so in some of those situations, all you need to do is just increase your eye time. But even in the more severe ones where they still are having an asthmatic event, sometimes I've found dropping my rate to a single digit number, 8, 9, and using a 1-to-1 works really, really well in those to oxygenate, because you may not be able to do anything about the CO2 levels coming up in some of these.
Correct. And just to feed into what you're saying, you can look at your current waveforms now. If you look at your flow waveform, I want to freeze it real quick. You're able to physically see your air trapping right there. I've got the cursor moving. So we're not getting back to baseline. So your machine is giving you that visual. You don't need to press any buttons. We're using that waveform to our benefit to see that. So there's going to be where more of your turning the rate down is going to come into play. And I'm going to feed into everything you just said. So I'm going to drop my rate down to 10. I've cut it in half. So from an air trapping standpoint, we may be in pretty good shape.
When I look at that, I go, well, I could see now that inspiratory wave is canceling out because of the eye time, right? Whenever I see that inspiratory line make a straight drop, I always think, well, if I increased my eye time, I could probably get a little bit more volume out of that.
Right. But if we are truly doing an asthmatic now, we've turned the rate down to fix the expiratory side of things. And other than a disconnect, that is the fastest way to increase expiratory time. Turn your rate down, your changing cycle time. That is the fastest way. If you look at our example now, we've provided enough time to exhale, but our exhale tidal volumes are not where we want them to be for this asthmatic patient. Your best option, as you said, remember, tidal volume is flow and time. Flow per unit time equals volume. So I'm going to add a quarter of a second, 0.25 seconds to this eye time. And you can watch your exhale tidal volume. And we're from 290 to 340. If we look at our flow graphic, we're still getting pretty much back to baseline. And we're still good.
And I'll be honest too, sometimes when I'm looking at that coming back to baseline, like once it gets close, you may have an asthmatic that it would take them, and you can look at your RCX and pretty much determine how long it would take them to get to baseline. Sometimes you're not going to get to baseline. However, if I notice it comes up and it's just riding real slow, I'm okay with it not coming completely to baseline because that may be waiting around forever for that. What is your thoughts on this? If I am auto peeping or I'm air trapping and I can see that air trapping is causing me to maybe have a little bit of residual pressure inside the lung, what's the purpose of even having PEEP on in an asthmatic?
Good question. There will probably be a fight between the transport side and the hospital side on this as to what happens. If it's that bad, you have an RS of 102, I'm probably going to do this. PEEP to 0.
Yeah.
Because you have a patient whose lung disease is expiratory resistance. And when we add PEEP, we're giving them more expiratory resistance.
Yeah, so it doesn't make sense to me. The argument for PEEP is that it makes it easier for them to trigger a breath, but I'm paralyzed. At the point I get to where I'm intubating an asthmatic, they're getting paralyzed. They're not triggering a breath at that point.
Yeah. So to take that one step deeper, that is a concept that's out there. If you dig deep into pulmonary physiology, you can try to find something called equal pressure point inside the lungs. And you're looking at the airway. You're trying to equilibrate the airway pressure to the pressure inside your lungs. Inside the hospital, you might be able to drop an esophageal balloon and measure transpulmonary pressure and find that. Or in some cases, if you're using an EDI catheter for phrenic nerve changes, you may be able to adjust PEEP and watch that to find out when the patient starts to be able to trigger their breaths much easier. But that's a monitoring capability that we do not have.
Yeah.
on the
I
outside. And honestly, we don't need to be messing with it because we're here to transport, not to consult. And, you know, it's easy to, we can get tied up in this data and lose sight of the patient needs to go somewhere where they can be, have a higher level of care done. And we don't need to be screwing around. But in the absence of that, PEEP's going to zero. I agree with you. And then we'll move about that way to try to make things better. The high CO2 is not going to kill them.
right.
It is not. Maintain your blood pressure, maintain cerebral cruising pressure, keep their pulse ox where it needs to be. Your brain, remember, it loves oxygen and sugar. Make sure it gets it.
One of the things that's interesting is in a patient who has, let's say, asthma, and it's a real bad asthma attack, and they're intubated. You do have a concern at some point that they could have a pneumo, right? And so the pneumo, what's interesting is like in the helicopter, when we're using ultrasound, if you see no lung sliding, it could be a pneumo. It also could be hyperinflation of the lung that can cause that same issue.
Yeah.
And so if you can't really use ultrasound, you're using your pulse ox, but you could have a low SpO2 in an asthmatic as well.
Yeah.
Now, when I ask new clinicians, new flight clinicians, and I'm quizzing them on the T1, I go, okay, your patient just got a pneumo. What would you expect to see on the T1? And everybody goes, oh, your pips are going to jump up real high in that case. And it's interesting because that's not what's going to happen, right? If it could, maybe if it hits your alarm limit, but when you are setting the inspiratory pressure, that's the pressure, right? It's delivering that pressure. The only thing you're going to see is your exhale tidal volume start to come down drastically. So do you have any tips or tricks to say, hey, this asthmatic just got a pneumo? What would you be looking for?
It depends.
Yeah, right.
The older I get, that's my answer. It depends. If you're walking into the hospital and their vent settings are just totally not appropriate, their rate's high, their compliance is low because they're overdistended, with that imaging, you may have a hard time telling if it's simply dynamic hyperinflation or a pneumo that's occurring. With appropriate settings, if we're getting some decent return tidal volumes back, even though our rate may not be high, in that case, I'll still watch the static compliance number. I would still watch it. Because if I were going along, and this is the picture that I had, our rate slowing, we're getting decent volume return back. And then at some point during our trip, you saw this occur.
So you're making the C stat drop. For people who are listening to this, so you can see the C stat coming down.
Your static compliance is taking a dump. It's going down. That's going to be a visual cue there that something has changed. Something has changed. RNs didn't change. Probably not an airway issue. We need to get on the chest. Whether it's listening, whether it's ultrasound, we need to get on the chest.
Yeah, you'd probably see your oxygenation tank C-stat start coming down.
Correct.
And you'd have the indication that, hey, and, maybe you can see something on the chest, like visually, but, I wouldn't bet on that. But yeah, that can be a tough scenario. I always thought that would be a good simulation scenario because it's difficult. And the thing is when you needle the chest, and you put the ultrasound back on, you're not going to get that returning of lung sliding all the time. There's always a little bit of residual air in there. So you just would look to see if your C-stat comes back up and then your oxygenation comes back up as well.
Have you ever run into the dynamic hyperinflation piece in transport? I've seen this a couple of times where you have a bad asthmatic and you roll in, and that's what you find.
So they have a really high rate. They went to 1 to 4.
Oh my God, CO2's 100. I got to blow it off. Rate times solid volume equals minute volume. Oh, turn it up. So
yeah, no, I've seen that. I've seen that too in a metabolic acidosis where they try to make that minute volume up with rate instead of actual minute volume.
Right.
But yeah, back to the asthmatic. You go in and see this. What's your first move?
Here's your vent presentations, but more importantly, you walk into the room, you'll probably hear it before you see it. You walk in, you hear the alarms going off, and your patient's heart rate is 165. Their blood pressure is 75 over nothing. Their pulse ox is low. And essentially what is going on here, you can see all this air trapping that's been occurring for God knows how long. Your transpulmonary pressure is getting close to exceeding your systolic blood pressure. And you'll have a pulmonary cardiac tamponade develop because the pressure around the heart becomes higher than what's in it. And you'll see a PA arrest occur. When you get there, if you see that presentation, an asthmatic and they're tachycardic and hypertensive, look at your ventilator. Now, I know we teach people, turn the rate down. But if you're in dynamic hyperinflation, this is what you need to do. Disconnect. 3 times in my career, I've actually got on the chest. 2 times, we set the patient up. They were small, and we bear hugged them. And then the other time, the patient was very large. We laid them flat and actually pushed on their chest, and you could audibly hear wheezing coming out of the ET tube as we squeezed or pressed on the chest. You want to disconnect from the vent because it's killing them. It's killing them. Squeezing the chest or getting on the chest and pushing on it will help get that air out and help reset the playing field. Then you can get your vent settings down to more appropriate place. All 3 of those times, we actually took a suction catheter and attached it to some low flow oxygen tubing, like with a nasal cannula, and threaded that suction catheter down the tube just to give some oxygen while we pushed and got the air out.
Oxygenating while you're doing manual exhalation.
You may have to press or squeeze on the chest for 2, 3, 4 minutes to get that air out, depending on how severe it is. But it's almost magical. You start that squeezing and you watch the heart rate start to come down and the blood pressure starts to get better. And you've realized what a gigantic bullet you just dodged.
So that's in my thinking, that's one of the only reasons I can see to pull the patient off of a ventilator. And I see sometimes with alarms, a lot of times you'll see they disconnect and they switch to a BVM and the alarms go away because obviously there's no alarms on a BVM.
The issue's still there.
You're losing the data points, right? You're not seeing the numbers. What reasons are there? Is there any reasons besides that you should disconnect the patient from the ventilator and try bagging them?
If you suspect there's a device malfunction, sure. Absolutely isolate it and see what's going on. As you said, you lose some diagnostic capability, but if the device is messing up, then that capability is not worth anything anyway. Other than a device malfunction, or if your patient's about to code and you really can't quickly assimilate what's happening, you might go to the BVM then just to run down your checklist and make sure that you're eliminating things. Is it a patient issue? Is it a device issue? But once you have that figured out, if it's not a device issue, you might want to get your device back on and then start looking at the diagnostics it's giving you to maybe work more towards a solution. Make sure your patient's oxygenated, obviously, go to 100%. And then we can work on the ventilation side because that's probably what the alarm is going to be if it's a ventilation issue. It's a high area pressure at some point and we're just fighting it.
Here's a weird question, and somebody asked me this, and I had to really think through it. But you knowing the backside of the T1 better than anyone I know, you may be able to give some clarity on this. If you had a total device failure, the T1 just absolutely just stops working, right? And I shouldn't say it stops working, but you feel like it's not ventilating appropriate. If you were to take your flow sensor and attach it to your BVM and ventilate the patient with it, would you get readings off of the BVM if you just use the flow sensor on a BVM with an endotracheal tube?
It would alarm like crazy, but yes, because the flow sensor's a dumb piece of equipment. It's there to measure.
It would go right on the other side. Yeah.
Yeah. It really doesn't care where the measurements are coming from, but the measurements you see will come from BVM. So yeah, that's something that can be done. You're just going to have a noisy box while it does it.
Awesome. Well, Joe, you're a wealth of knowledge on this, man. I've really appreciated years. I've been texting you and emailing you about this stuff. And I think this is great for like the first couple of things. This ventilator does a ton of stuff. And so I think maybe we could do another one of these just to try to keep them short and concise too. But I really appreciate you coming on. And any ending words of wisdom on the stuff we talked about?
I tell everyone, you're getting a new machine. If you're new to this, don't try to reinvent the wheel on the front side.
Yeah.
Try to take your current practice and move it into this device. And once you've wrapped your mind and your hands around that, then you can start to add things and start to grow more with it. But that's the wonderful thing about it. This is even though this machine does hundreds of things, it's very well on the acute side. It's easy to use. Or if you want to start making it complex, then it can feed that appetite too. It's a really nice device. It's not perfect, but it's close.
Awesome, man. Well, Joe, thanks so much for coming on, and we'll talk to you again soon, man. Be safe flying.
Absolutely. You be safe as well. Good seeing you again.
All right, so we just watched the episode, and you got a list of some things that you wanted to talk on, some talking points, and I think these are great, especially when it comes to, like you mentioned, some of the nuances, some of the things to train for, practice with. So we'll start off with the first one you had, which was the SimV versus PCV.
Yeah, and it could go for, with the Hamilton specifically, it's like a pressure control typically that you're using to deliver most of the tidal volumes. But just to clarify the difference between those, like when you have a pressure control breath, as soon as a patient triggers a little bit, they just have to trigger once, whatever your flow trigger or pressure trigger is set to, and then the vent is going to ramp up regardless of what they really do after that. And it's going to ramp up if you have your peak pressure set to, 25, it's going to go right up to 25, even if they have no more activity in their chest. Whereas with those pressure support breaths, it's just like BiPAP, like when somebody's on BiPAP, they can take these huge breaths and they can just like keep triggering the vent, and it keeps adding that pressure support to them as they breathe in. Again, those SimV breaths, whenever they take a spontaneous one, it's going to be pretty much just like BiPAP. And I've thought about that problem a lot where, some people will be like, I'm just going to put everybody on SimV because if they do start to auto trigger or something like that, it's only going to be these pressure support breaths, and it's not going to hammer them with the full breath every single time this thing cycles. And when I started off doing vent transfers, I took a lot of patients that were on long-term acute care or at, a vent facility or whatever, and they had to go in for an appointment or something like that. So you're sitting with these patients that are not sedated at all. They usually have a trach. You're sitting with them for a long time. And if they would auto trigger a little bit, or we had some problems in transport, it's too bumpy and all of a sudden the vent starts triggering or something, or whatever ends up happening, I did this, I'd switch them over to SimV, thinking, well, this will fix this auto triggering issue and, we'll be all good. And they hated that. There's a certain patient population when they're really with it and they're used to just putting in that minimal effort to just either suck in a little bit of flow or drop the pressure slightly. And they're used to that big follow through of a breath for them putting in minimal effort because maybe they have muscular dystrophy or like whatever their issue is. It seems like the more used to those settings that the patient is, the more they're bothered by you abruptly switching them to SimV and having to continuously trigger the vent when they're just used to, dropping that a little bit, triggering it. It gives them the full breath. And so that's one scenario where I can see like it can actually cause some distress for the patient. Whereas, when you have those more recently intubated patients or they're on moderate sedation and you're taking a transfer or something, they may have been on it for days or something, they might be more comfortable on those SimV settings, but that's just what I've experienced. There's 100 scenarios that you could go into, but those longer term patients, minimal sedation, they really like their predictable vent settings, and they usually respond really well to like increase the flow, like what Joe was talking about, like increase the flow a little bit, hit them with the pressure a little bit sooner, maybe a slightly larger tidal volume, or maybe, just an increase in breath rate, just a tiny bit so they don't have to trigger so often on their own. Those things typically go a long way with those patients.
Yeah, and typically you find that they're more comfortable with a lower P ramp, right? So the time it takes to get to your inspiratory pressure. However, there are some cases like we talked about in the obstructive patient where extending out that P ramp can avoid you from overshooting that, which I know we talked about this over the weekend. Sometimes you can overshoot the inspiratory pressure, especially when there's really high resistance. So extending out that P ramp can help you with that as well.
Yeah, totally.
Next I have on here test lungs. So You
Yeah.
mentioned a little bit in the beginning how you can modify and do some clandestine improvements or modifications
Mhm.
to your test lung. What were some of your thoughts on that?
Yeah, so using test lungs in clinical care, Joe had a really good point about, yeah, if you have a PRVC mode where it has to have some type of breath return from the patient or from the test lung or whatever, if it doesn't have that breath return and you're just venting into the open air and the circuit pressure is like zero and nothing is coming back, yeah, it's going to continue to try to figure out what's going on. And I've also noticed that, I don't know if the T1 does this, maybe you could tell me if it does or not, but does it ever hit a blower demand exceeded?
I have never seen that alarm, but I do know I can't remember what the similar nomenclature is for that, but I have not seen it because with the C long hoods that we were using for
It's
transport,
constant high flow.
yeah, we would put a controlled leak in that, and
Mhm,
that's what would actually provide the flow. So,
mhm,
you'd have a PEEP valve and you'd have like the filter, so you're not,
mhm.
obviously filtering or putting
Yeah.
out COVID into the air, but we'd have a filter and then a PEEP valve, and
Mhm,
then we could control the flow with how much PEEP we added. And so it was a controlled leak that actually made the ventilator want to maintain a certain amount of PEEP inside the mask, and so, you could get really, really good flows, really high flows on that. So I
yeah,
haven't seen a
that's
blower demand exceeded like we used to see on the Envy,
mhm,
where you would have somebody with a leak in their BiPAP mask or something, and it would do
mhm,
the whoosh, 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 and then
mhm.
just stop.
But it cuts off after a certain amount of time, so I don't know how many vents do or don't, you'd have to test it, and it's real easy. I mean, take your vent, either put it on, like, your non-invasive positive pressure setting, so whatever your BiPAP is, or your PRVC mode, and see what it does when you just have the circuit open to air. See if it'll just keep trying to deliver that breath, and then put a test lung on and see how long it takes to calibrate. Or I think one of the main areas I've seen test lungs be really helpful is when you set up your non-invasive settings, you put it on the test lung, and at least it's not blown out into the air. And that can give you a little bit of a smoother transition when you're going from your ventilator, because sometimes your masks aren't compatible, right? They have a vented mask and you have a non-vented mask, or whatever the case is. Theirs isn't fitting well, so you're going to try to resize it or something like that. And there can be this kind of like in between phase. And in those vents that do that, or they don't just continuously provide that flow, and they kind of error out when you're just ventilating the air, which you're not, supposed to be doing. It should have some type of back
It's having
pressure
a
on it.
hard time maintaining the PEEP of the room.
Yeah, exactly. Yeah, it'd take a lot of flow, right? And that can ease that transition a little bit. Put it on a test lung, and then once you're finally ready to switch it over, do that a little bit more quickly. And I've found that that can help reduce some of those errors. And then I had one more thing. I'm just checking my notes here. I had one more thing about the test lung, and it was when you're searching for errors. So you guys were talking about the scenario where you disconnect somebody from the circuit because they have crazy auto peep and it's essentially turning into like an obstructive form of shock. So you disconnect it, and he's talking about bear hugging people and pressing on the chest and stuff. And, there's definitely going to be other times when people disconnect the ventilator because, they can't figure out the alarms. And like you were saying, the bag valve mask doesn't have any. So it's a really nice break for your ears, right?
Mhm.
And there's two options when you disconnect that ventilator, which a lot of people will just go ahead and put it into standby, or they'll turn the ventilator off and say like, all right, we'll check back on that problem in a second. Let's just see what's going on here. I think a better plan, and tell me what you think about this, is just put the ventilator onto the test lung, because there's nothing wrong with that test lung. It's got good resistance and compliance. And if the ventilator starts acting totally normally when you have that test lung on there, then you should have some idea that this problem, whatever's causing this ventilator to go crazy, is either somewhere between the ET tube connector and the alveoli, or the surrounding tissue, their chest, their activity, whatever, or
Mhm.
some type of interface between how the patient is reacting to that ventilator. So I think you're kind of leaving some information on the table when you don't put it on a test lung, when you do have to disconnect the ventilator, because then if there are some settings that you want to adjust, just do it while it's on the test lung, and then you can try again shortly afterwards. If you put it in standby, it's like, would it have kept alarming even when it was on the test lung? Is this a settings issue?
Yeah, that's a great way to kind of eliminate the machine as being the issue
Mhm.
as opposed to the patient. I remember, um, I remember I was on a call with Matt Sox one time. Same thing. Like we kept taking it off, putting it on, and we kept getting really high leaks. And it turned out that it was a cuff leak, right? But
Mhm.
disconnecting the patient and putting the ventilator on the test lung and letting that work for a little bit really helped eliminate the ventilator as being the issue there. And I remember even when we would set up the vent before we would put it on the patient, we would hook it up to the test lung. And that really gives you even more, confidence when you do connect it to the patient that
Mhm.
there's no leaks in the circuit, the little water trap isn't loose or
Right.
something. And then when you move it to the patient, it's like, okay, well, obviously there's something between this ET tube connection and the patient's respiratory system.
Yeah. Last point I had was about the obstructive patients because I love the 1 to 4 to 1 to 1 I to E ratio discussion. That's actually what I came into the office to play around with on the vent. I was like, man, how good of an alveolar tidal volume can I get if I have a standard obstruction and I haven't changed this. Let me see how big of a breath I can get and move it really slow. But there's definitely if you switch from one to the other there's definitely a different mindset that goes into your peak pressure. Like when you're doing that 1 to 4, you're with your total cycle time, like your inspiratory time is taking up a very short amount of time on that total cycle time. So you slam it in really quick, and then it's supposed to come out over the next, say it's 1 to 4. So you have like 1 part in and then 4 parts out. And usually your respiratory rates maybe a little bit higher, maybe your tidal volumes aren't as big, and you're just watching this tidal volume exhale come back. But with that peak pressure, when you're pushing that breath in really quick, let's say that your flow is like, it's 60, 70, 80 liters on the way in, you're accepting these really high peak pressures and you're kind of relying on the tidal volume exhaled to say like how much of that actually made it to the alveoli. So you're kind of using that like tidal volume exhaled as a surrogate of like, is this an appropriate tidal volume? Like how much pressure is actually going down to the alveoli? And when you switch to a really low flow, less of that peak inspiratory pressure. So let's say, you go from a flow of 80 to all of a sudden it's 20. You have to like completely reorient your brain about how you respond to a peak pressure because that flow is going in so slow that less of that pressure is taken up by the initial resistance of the airways. And it's more so about the compliance of the lungs. So let's say you switch to a 1 to 1, breath's a little bit bigger, it's going in really slow. That peak pressure underneath that slow flow, that like let's say it's a 1 to 1 or something close to that, it's going to be really close to your plateau pressure. And especially if you're using like a PEEP of 0, then you could be looking at a driving pressure go from just about 0. They're always going to have some remaining PEEP inside their lungs, so not exactly, but according to the vent, going from 0 PEEP all the way up to 30, all of a sudden you got this huge driving pressure, and you can't think about that or that peak as being all resistance anymore. Like at some point, if that flow gets slow enough, it's going to be really close to your plateau pressure.
Yeah, and I would say that's really true too when you're looking at something like we're volume versus pressure mode as
Mhm.
well. Because in the with the Hamilton T1, like you look at your space underneath the flow curve,
Mhm.
and you look at that and you're like, okay, I'm flowing, maybe 60 liters a minute or whatever,
Mhm.
but I'm only doing that for a brief half a second or
Mhm.
whatever. And you're like, if I was blowing that and you actually march out the calculation, it's not like you're staying at that 60 liters. It's a
Mhm.
decelerating flow waveform. So you're quickly ramping down. And I always liken it to when you're pumping gas and you're getting close to the price. If you prepaid, you're getting close
Mhm.
to your $20. It starts slowing down so they don't
Mhm.
give you more gas than what you paid for. And I see the ventilator doing the same thing. And so your P ramp, if you really want to get that in quick and you want to really come in punching high with your flow, turning that down will obviously do that. But at the risk of, like we mentioned, still hitting, maybe overshooting your peak inspiratory pressure, which I didn't know you could do that on a pressure ventilator, but you can. And so I thought that was interesting. But yeah, it's two different mindsets. I
Mhm.
like what Joe said when he mentioned like the easiest thing you can do when you walk in and somebody's air trapping like crazy is turn the rate down. Yeah, you're right.
Mhm.
We can play with I times and stuff like that, but that's a quick way of dedicating time and allocating it to both I time and E time really quick. And I like that a lot. And as long as it's not like a metabolic acidosis asthmatic patient, you know, your CO2s are going to be fine. They're going to rise probably, but then they'll get better with time.
And sedation and paralysis helps with that when those patients are super air trapped. And you can drill it with just a squished piece of tubing. It's pretty easy.
Awesome. No, great point, Sam. And I hope everybody enjoyed the episode.
Till next time, guys.